Hopefully we're going to follow on from those amazing talks with a few more. This is going to be a bit more quick-paced, and actually it's the first time we've integrated the abstract session into the main auditorium session. So I really hope a few more of you get a bit of a snapshot of research and really feel that this is worthwhile for everybody who contributes and has put in abstracts. We've had a record number this year submitted, and as I said in my talk before, the quality has improved considerably. So please, if you are thinking for next year, and do think right now about submitting for next year, we'd love to see them. So, get in touch if you need any support, but hopefully this will give you a bit of a taster of the high quality that has been submitted. So first up, we have Zoe Rogers today, who's going to talk us through evaluating CRT and myocardial work efficiency in patients with right bundle branch block and left bundle branch block. So welcome, Zoe.
Thank you. Okay, so my name's Zoe. I work at the West Suffolk Hospital, and this is the project that I completed as part of the third year of the SDP, and it was an evaluation of the effect of CRT on myocardial work efficiency in patients with underlying left bundle branch block versus right bundle branch block. So in current guidelines, patients with both left and right bundle branch block are eligible for CRT. However, it's generally accepted that left bundle patients respond better, and therefore a much greater number of them are usually referred. Myocardial work efficiency is an emerging load-independent technique for analysing global and segmental contraction patterns. It quantifies both wasted work and constructive work based off of when the aortic valve is open and closed in order to give a work efficiency percentage. Studies thus far have demonstrated significant disparity between septal and lateral work efficiency in left bundle patients, and that is then improved post-CRT. So you can see in the bottom image on the screen, areas of red indicate low work efficiency and areas of green are higher work efficiency. So pre-CRT, the septal regions were quite low work efficiency, and then post-CRT, they were much improved. Studies comparing myocardial strain have showed significantly less dysynchrony in the right bundle patients compared with left bundle patients, but myocardial work hasn't really been applied in this cohort yet. So myocardial work could potentially aid in the analysis of mechanical contraction patterns and help to identify patients who are likely to respond to CRT. So the main aims of the study were to compare the effect of CRT on myocardial work efficiency in patients with underlying right bundle versus left bundle branch block, and to assess the differences in baseline patterns. So data was retrospectively collected for 3 years, and I had 2 groups of 10 patients, group 1 being underlying left bundle branch block and group 2 being underlying right bundle branch block. All patients underwent standard echoes pre and post CRT, and myocardial work analysis was performed. Segmental patterns were compared at baseline and post-therapy, and the effect of CRT on global and regional work efficiency was evaluated in each group. And correlations between the change in global work efficiency and changes in other baseline variables were assessed. So in terms of results, the baseline global work efficiency was significantly lower in group 1 compared with group 2, despite no differences in any of the other baseline characteristics. Interestingly, there was no significant correlation between baseline global work efficiency and baseline EF in either group. Global work efficiency was significantly improved post-CRT in group 1, but did not change in group 2. And in group 1, there was a strong correlation between the improvement in global work efficiency and reductions in LV volumes. Finally, baseline septal work efficiency was strongly associated with the degree of reduction in LV volumes in group 1. So in the left bundle group, the overall pattern was in keeping with previous research, showing high lateral work efficiency scores and low septal work efficiency scores. And 7 patients in that group responded. And in the top image is an example of a responder, so you can see that pre-CRT, the septal work efficiency is quite low and lateral work efficiency is quite high, and then post it's much improved. Of the 3 non-responders, 1 showed a similar pattern, which it didn't really improve. The other 2 showed quite good baseline work efficiency patterns, and therefore potentially not much to improve upon, and that's the bottom image, pre and post-CRT of a non-responder. So in the right bundle patients, there was no consistent pattern prior to therapy. And only 2 patients showed a significant response. The 2 responders showed poor apical work efficiency, which actually did improve post-CRT. And of the non-responders, again, they tended to show quite high work efficiency global work efficiency at baseline and not much improvement. So again, the top image is a responder pre and post, and the bottom is a non-responder pre and post CRT. So overall, this study suggests that response to CRT is related to the baseline level of mechanical desynchrony, and that can be quantified via myocardial work efficiency software. There is less mechanical desynchrony in right bundle patients, which appears to result in higher global work efficiency and then potentially less substrate for improvement via CRT. The baseline patterns in left bundle patients was in keeping with previous research, and that supports the theory behind lateral lead placement of the LV lead in order to accelerate lateral wall contraction and improve synchrony. And finally, baseline work efficiency was associated with the degree of LV remodeling. This suggests that myocardial work efficiency software could be valuable for identifying patients who are most likely to respond to CRT. So obviously it's quite a small study, I only had 20 patients, so further research with greater sample sizes is needed to assess whether myocardial work could identify patients with right bundle who do have underlying desynchrony and may therefore benefit from CRT. More studies in left bundle patients are also needed to determine whether myocardial work is worthwhile as opposed to just relying on ejection fraction when selecting patients for CRT. And finally, research should also assess whether myocardial work can guide LV lead placement for better response to CRT. Thank you.
That was brilliant. Thank you so much, Zoe. And I could honestly talk to you about this all day. I won't dominate the questions. We will stick to some of the ones that have come in. I think it's really interesting. And to be fair, one question has come in around this. You ended up using LV end diastolic volume for your predictor of response for the determinant. Can you just describe why you chose that?
I think just kind of looking at some of the previous studies, that's what a lot of them tended to do. Obviously, what my findings were that both LV and systolic and end diastolic volume both improved in the left bundle group, so you could probably use either, but that's just what I went with because of previous research.
Brill. There's a couple of others. So did you correlate myocardial work efficiency with QRS duration?
I did, yes. I think in both groups, QRS duration did reduce. So it's quite a short presentation, so it's just not one of the main findings. But yeah, so electrically it did improve, but mechanically potentially not in the right bundle.
Which is really interesting, isn't it? Because it shows that there's such a disparity between actually what's happening physiologically with what's happening with the electrics. And
yeah.
Brilliant. There's one more question. You mentioned you were surprised there wasn't a correlation between global work efficiency and ejection fraction. And did you have any thoughts about what that might be?
I just think that the guidelines are very based on ejection fraction, so kind of anyone with an EF of less than 35% and a broad QRS, we start thinking about putting a CRT in. And I don't know about other trusts, but we're not in the habit of doing myocardial work or anything like that to see if patients actually have desynchrony, because you can have a low ejection fraction but not necessarily have the desynchrony that's going to improve with CRT.
Well, and actually, to be fair, there's a randomised control trial going on at the moment looking at some of these measures in patients and whether it's predictive or not. So we've got loads more to discuss.
Yeah.
Congratulations. Cool. Thank you.
Thank you.
Thank you, Zoe. That was a really, really good presentation. So next up, we have Christopher Wild, and Christopher Wild is going to be presenting his work on echocardiography, echocardiographic assessment of pulmonary hypertension and novel markers to help identify pulmonary hypertension secondary to left heart disease.
Thank you. So my name's Chris Wild. I'm an early career researcher and physiologist at the Royal United Hospital in Bath. So we recently undertook an audit of a fairly recently proposed algorithm for differentiating pre- and post-capillary pulmonary hypertension. And we also assessed measurable parameters against a raised pulmonary arterial wedge pressure. Here we go. So pH secondary to left heart disease is distinguished from pH arising from the lungs by pulmonary arterial wedge pressure in excess of 15 millimeters of mercury, as measured by invasive right heart catheter. It's the most common form of the disease and is not treatable by medications that we use to treat precapillary pH directly. There are a number of existing algorithms that have been proposed to detect these specific types of pH, but a lot of studies have shown these to be relatively imprecise. A number of echocardiographic measurements have, however, pretty much consistently shown a correlation between both pre- and post-capillary pH. We selected our retrospective cohort from 503 patients, consecutive patients, who underwent both transthoracic echo and right heart catheter, referred for first-time assessment of pH at a national pH centre. Full complement of measurements was obtained, including both those present within the BSE minimum dataset and those within the pH assessment guidelines. So we first assessed a recently proposed algorithm in 341 patients with sufficient image quality to obtain a full set of measurements. This algorithm in particular is designed to distinguish pre- from post-capillary pH with markers of diastology as well as left atrial reservoir strain. Our analysis of the individual markers showed all of them to be significantly different between pre- and post-pH, barring lateral E by E prime, which in this case is used in the absence of a measurable strain. Following a full analysis of this cohort, we found this proposed algorithm to be 89% specific but only 31% sensitive for post-capillary pH when it was applied to the current hemodynamic cutoff of greater than 20 millimeters of mercury. So it's important to note that this algorithm is presented to predominantly screen for pre-capillary pH, and the original analysis was in fact based on the previous definition of pH by mean PA pressure. And due to the measurements required, only patients with AF or otherwise no measurable A wave are unable to be assessed by this algorithm. So we then undertook an analysis of a larger cohort, 402 patients with confirmed pH, and assessed left and right atrial geometry and strain, as well as LV function against the pulmonary arterial wedge pressure cutoff of 15 millimeters of mercury. This cohort was comprised of 74% pre-capillary pH patients. So we found that atrial measurements were significantly different between individuals with pre- and post-capillary pH, but interestingly, LV ejection fraction and global longitudinal strain were not found to be different. Using our best performing parameters, we aim to develop a tier system using a combination of receiver-operator characteristic scores and, where applicable, established cutoffs. So when assessed for use in detecting pH secondary to left heart disease, we found that the overall difference between the high and low tiers of these measurements was significant, but in most cases, those within the intermediate brackets were too similar to allow for these markers to be utilized individually. So to reduce the effect of this, we assessed the ability of a combination of markers to identify the most common form of pH. Using index delay volume, left atrial reservoir strain, and mitral valve E by E prime, which are becoming increasingly common measurements, and particularly strain in most modern echo labs, we applied a point scoring system, and using a combination of at least 2 of these displayed values, we were able to identify post-capillary pH with a good sensitivity of 85% and an acceptable specificity of 68%, and that's based on the current definition of the disease. So this was an exploratory study and thus does present a number of limitations, but we aim to develop this algorithm further in the future using a far less skewed cohort and to utilize some of the other markers of function which performed well in our testing. This will likely result in a decision tree of some sort. This algorithm and future iterations will, of course, have to be tested on a prospective cohort. This system uses common measurements which can be obtained in most echo labs on what is rapidly becoming standard equipment. And we conclude that with further development, our algorithm could allow for better assessment of pH within non-specialist settings. This method could assist in improving the time to referral and thus formal diagnosis, and consequently access to the appropriate treatment in patients with post-capillary pH. Thank you for listening.
Thank you, Chris. That was a really excellent talk. It was really interesting to see the work that you've been doing with that. And it's quite a big increase in the your sensitivities that you were picking up. Were you expecting to see that?
No, no. I didn't expect the first set of results, to be honest. But I've noticed through looking at all of the currently used algorithms and recently proposed ones, a lot of them do focus on pre-capillary pH, I think because it's rarer. But if 70% of pH is secondary to left heart disease, that's probably what's going to be coming through echo labs. And given it's not treated by the same medications, I think it's equally important that we identify that as well. Bless you.
And I've got one more question for you, if that's okay. So in this study, you use in LA reservoir strain. We know that sometimes if the image quality isn't great, we're not able to do that. Are you considering looking at the other measurements that we've got in the diastolic guidelines to maybe see if there's any kind of markers in there that we could use instead?
Yes, so actually quite a few of the geometric and functional measurements in the atrium, and actually a lot of the diastolic markers, they did perform well. So I think when we go on to develop this, we will look at everything that went well, but we had the best results in this early stage with these markers.
That's great, thank you very much.
Thank you.
And next I'd like to invite Dr. Hao-Tian-Gu, and just whilst he's walking up, I'm just going to explain a little bit about the process of how the speakers have ended up where they are today and presenting. So when the abstracts come in, we have a whole host of people that review them and grade them based on lots of various components, and then we invite the top sort of 4 to 6 speakers, depending on the session that we have. And actually, Dr. Gu is going to be presenting twice today because all is fair in love and war, and 2 of his abstracts made it into the top. So this is one of 2, basically. Thank you.
Thanks, Maria. Hi, everyone. Hi, my name is Hao-Tian from King's College London. So the first talk I'm going to share with you today is about blood pressure and LV function. So the question is whether if we lower the blood pressure a little bit further compared to the current guideline, whether that would help in preserve the LV systolic function, particularly in children with chronic kidney disease. So a bit about the trial. So this is called the HOTKIT study, a HOTKIT trial, which is a UK-wide randomized control trial in children with CKD. And so we randomized children into 2 arms. Intervention arm, we reduced that blood pressure a bit further to below 40th percentile. And the standard treatment arm is between 50th to 75th percentile for their age. And so then we follow them up and to compare various different parameters, for example, LV remodeling, diastolic function, and systolic function between the 2 trial arms. So next page. So this is the primary paper we published in recently. And so what we found in this primary paper is we found, so with more intensive blood pressure treatment, so they reduce relative wall thickness in the, you can see from this graph here. So this is show the annual rate of change between intensive treatment arm and standard arm. So you can see so the change from baseline reduced a bit further in the relative wall thickness compared to the standard treatment arm. So that's the primary finding in this trial. So the data I presented last year in the BSE conference was we look at the diastolic function in the 2 groups as well. So we look at the E/O/A ratio. So it's there's significant difference. We can see that in the intensive treatment arm, so the rate of change is sort of like preserved, while in the standard arm, so there's slightly lower or reduction of E/O/A ratio in the standard treatment arm. So then septal E prime. So again, so in the intensive arm, there's sort of preserved over the years of follow-up, while there's slightly reduction in the standard treatment arm. And similarly to left atrial volume index, so slightly increase of left atrial volume index, while in the intensive treatment arm, there's a slightly reduction of the left volume index. So what happens to the systolic function? So obviously, we'll look at ejection fraction. So then we'll look at this first phase ejection fraction, just in case of you don't familiar with this measure. So this is the ejection fraction measure up to the maximum of myocardial contraction during systole. So we use the time to peak aortic flow velocity measure from Doppler to define this time point on the volume curve. So again, we'll look at the systolic tissue Doppler S waves and longitudinal strain. So what happens to them? So this is the baseline demographics. So just to look at the difference between the 2 arms. So they're pretty much identical groups. So then this is the baseline systolic functional measures. We can see that again, so the volumes are identical and ejection fraction is similar, and tissue Doppler, and so basically so majority of the volumes and systolic functional measures, they're all identical between the 2 groups. So then we perform intention to treat analysis using the mixed linear model. So there's no significant difference of ejection fraction and S waves between the two treatment arms. So then what happens to global longitudinal strain? So this table is showing the rate of change per year. So what we're looking at here is you can see at the year 4, so there's a significant difference between the two treatment arms. In the standard arm, so their average strain is a bit lower compared to the intensive treatment arms. So which means in the intensive treatment arms, so they're fairly preserved throughout the follow-up period, whilst there's slightly trend of reduction in the standard treatment arm. And again, so you can see from this figure here, so but bearing in mind is a change in strain. So obviously, being higher the change, the worse the condition. So you can see in the standard arm, so the points are going upwards, so being worse, whilst in the intensive arm is sort of like preserved or slightly lower. So what about EF1? Again, similarly, so in the EF1, so at year 3 and 4, there's a significant difference between the two arms. So in the standard treatment arm, the mean value is a bit lower compared to the intensive treatment arm. And again, the trend you can see, so being higher towards that way, so it's better function, and lower is worse. So we can see in the intensive treatment arm, so the EF1 increases over time, and whilst in the standard treatment arm is preserved initially, then start to reduce at the year 4. So there's big separation in EF1. So the explanation behind that, for example, for EF1 is that we did a previous study. We're looking at children with various different stages of CKD, so being stages 1 to 4. We found that they all have preserved ejection fraction, whilst as the disease progresses, we can see the reduction, a lower EF1 as the CKD stage got worsening. So then goes back to this question on the title, does lower blood pressure preserve systolic function in children with CKD? So then it does. It has a favorable impact on systolic function as measured by longitudinal strain, as well as this early systolic function as measured by first phase ejection fraction. So I just left the summary slides of the findings from the trial. So open to questions.
That was brilliant, Paton. Thank you so much. Just a couple of questions coming in. The first one is, what age were the children included in the study, and were some post-puberty and then maybe in a state of LV remodeling?
So the inclusion criteria is for children between 2 to 15, because we're going to follow up them for 3 years. So then for 15 years old, when we follow up to 3 years, they're still under 18. So that's inclusion criteria. On average, so the mean age for children included in the study about 9 years old.
Okay. And how well was the therapy tolerated in the children, and was compliance good?
Yeah, it is difficult, I have to admit. It took us quite a long time to recruit these patients into the trial. But I think majority of children, they manage to tolerate antihypertensive treatments. Obviously, we have to sometimes increase the dose or put them on a different agent to control their blood pressure to meet the target. Yeah, so, but we managed to get it through. So I just got another slide to show you, maybe. Yeah, so for example, that's just to show the different antihypertensive treatment, two treatment arms. We can see that in the black bars, they're showing to children in the intensive treatment arm, they have more antihypertensive treatments to lower their blood pressure a bit further. Yeah.
And do you have any thoughts on the mechanism for the improved EF1 and whether that was likely reduced afterload?
Yeah, so by lowering blood pressure, obviously you decrease the afterload, reduce the resistance from the arterial system. So then ventricle tend to face a little bit less resistant. And from the primary paper we published, we show that it's preserved remodeling in these children. So it might be a combination effect of lower blood pressure and to cause reversal remodeling. Then obviously better LV structure and less LVH may lead on to a better efficiency of the contractility of the heart, as well as linked to diastolic function improvement. So it's all linked together.
And then I think just to wrap up, what are your sort of future perspectives? Where are you going to take this work next?
So, well, ideally we want to follow up these children a bit longer, and obviously to keep an eye on them when they go into adulthood and capture hard endpoints, for example. But because the trial has ended and the children has been put on back to their routine care, so we'll lose the trial effect now, so that's very unfortunate. So, but if that can be done in the future, then that will be ideal.
Brilliant, thank you. We won't clap because we'll just invite you to talk again.
Sure, I'll just stay on.
And your next study is really interesting because it's the first one we've had that's in an animal model submitted.
Sure.
So
Yeah, because I think we are a pretty much clinically oriented conference, so this is probably one of the few animal studies we do. So this is to look at early systolic function with myocardial fibrosis development in rats. So this is reverse translation. So far, when we've done the literature review on this EF1, first phase ejection fraction, that we found there are 18 clinical studies that have been done so far. And so 10 outcome studies and 8 descriptive studies. So now we know EF1, as majority of these studies to show as a good predictor or more sensitive in terms of measuring LV systolic function. But in terms of to assess or evaluate the mechanism behind it, it's very difficult sometimes to do in patients in a clinical study. So that's why I thought it's probably we can try to reverse this translation to do a basic science study to look at animal models. So that's why I introduced this reverse translation study in rats. So the design of the study is like, obviously, we do ultrasound, we do echo in rats. And obviously, you can see that you're all familiar with this view. It's a standard echo view, but just in rats. So then with animals is that we can look at their fibrosis development by sacrificing the animals at the end of the study, which we cannot do in real patients. So then the model we use is a pressure overload induced heart failure model. What that means, so we have 3 groups. Control rats, we do nothing. And we have sham means we do operation on the animal, but without intervention. We just simply open up their chest and close it. And so the final model is the heart failure model. So what we did was that we put a wrap around this aorta and to shrink the size, try to mimic, increase the afterload. It's similar like aortic coarctation, for example, or you can say it's aortic stenosis to increase afterload. So then, obviously, to do an animal study, the first step we have to do to validate this animal model. So then we didn't obviously echo on them. So we look at the aortic arch view. So we can see there's a bit of the narrowing there because of this aortic binding. So then we look at the Doppler flow, and you can see in the control group and the sham group, so the Doppler flow velocity is pretty normal, and there's a significant increase of the aortic flow across that narrowing area. It's pretty much like an aortic coarctation pattern. So then when we look at the slice of the ventricle, we can see there's a dramatic remodeling happening in this group of animals. So now to look at this a more detailed analysis, to look at the velocity across this narrowing, you can see, so this zero week means baseline, so before the operation. So week 1, 2, 3, and 4 after operation. You can see the velocity in this heart failure group has increased dramatically after the operation, 1 week after, and sustained at a high level, and similarly to the mean pressure gradient. And so this is to look at the heart weight over body weight at the time when we sacrifice the mice. So you can see at week 1, so the heart rate increase is already over body weight, its ratio, and sustained at a high level throughout the follow-up period. Similarly, heart weight over tail length is kind of to compare to the length of the rats. Again, similar pattern we can see, so increase from week 1 onwards. So now after validation of this model, so we designed a study as we randomly assign the mice into the 3 different groups. So then we do ultrasound examination at baseline, then each week throughout the whole study period. Then we sacrifice the mice at each stage. Then we assess their myocardial fibrosis. So results. So now let's have a look at their ejection fraction, what happened to their ejection fraction as disease progresses. Obviously, at the baseline, no difference across 3 groups. And at week 1, 2, again, so no significant difference between the heart failure, which is the green bar, and the control and the sham group. Maybe slightly lower trend reduction at week 2. But at week 3, there's a significant difference. So ejection fraction start to reduce at week 3 after the procedure, then reduce further at week 4. So now what happens to strain measures? So we've got a longitudinal strain, circumferential strain, and a radial strain. So for longitudinal strain, so trend of lowering at week 2 and significantly reduced at week 3 and 4. And again, circumferential strain, maybe a little bit lowering, but didn't reach significant. And at week 4, there's a significant difference, and no difference of the radial strain. So finally, EF1. So the interesting thing about EF1 is at week 2, you can see EF1 start to reduce already, whilst as the disease progresses, week 3 and 4 is reduced a bit further. So this is the marker actually start to reduce the first at the week 2 compared to ejection fraction and all various of different strain measures. So now let's look at this myocardial tissue staining. So this is to assess the myocardial fibrosis development. So you can see control and sham at different stages, there's no much difference. Whilst the heart failure group, you can see more of the bluish type, so there's more development of fibrosis as the disease progresses. So again, so we can look at the fibrosis area as a percentage value over all entire myocardium. So at week 1, so it started showing some sign of fibrosis development, but didn't reach significance. Then week 2, 3, and 4, there's a progression of the fibrosis development over the period of follow-up. So then we want to look at how the different LV systolic functional measures associated with fibrosis development. We did a ROC analysis. So you can see on this, obviously, the graph to show the area under the curve, and EF1 has got the largest area on the curve, and as well as strain, global longitudinal strain, and the EF, they all had a significant relationship with this fibrosis development, but EF1 had the largest area under the curve, being the most sensitive. So early systolic function of myocardial fibrosis development. So apparently, so from what we found, that EF1 is a more sensitive marker of functional reduction in this pressure overload heart failure rats. So it started to reduce at week 2 after the procedure. And also EF1 is being the most sensitive predictor of fibrosis development in these animal models. So again, I'll leave you with a summary slides on the screen, just open to questions.
Thank you, Hoshan. That was really interesting to listen to your work on that. We have a few questions that have come in for you. The first one is, if you increase afterload, you increase wall stress. Have you measured this, and how does this relate to your EF1 measurement?
Sure. So the first study we published, so we look at the EF1 in relation to myocardial wall stress. So we're using non-invasive blood pressure, central aortic pressure to calculate the myocardial wall stress. We found that, so with patients, so when the wall stress in the healthy heart tend to reach to the peak level early on during systole, then ventricle, the EF1 is preserved or is a normal value. Whilst in the failing heart, although the ejection fraction is still preserved, the pattern of the wall stress when reached to the peak is usually happening towards the late systole. So which means the heart has to sustain the contraction to maintain a high stress level to preserve the overall ejection fraction because of the initial push is weak. So in animal model, although we have not included the wall stress measure in this particular study, but because in the animals we can actually put a catheter in the aorta to actually measure the invasive central aortic pressure to calculate the myocardial wall stress, which is supposed to be a more accurate measure. So yeah, that's a very good suggestion. We could certainly look at that.
Thank you. The next question, if that's okay,
Sure.
is what do you think are the limitations of strain in small animals with high heart rates? How accurate is GLS in this setting?
Sure. So we use a specially designed animal echo probe with high frequency. So, and also all the animals are being sedated, so their heart rate is fairly stable. Although usually in rats, their heart rate is around 400. Cannot compare with humans. So with all these softwares and the probes equipment, we use this dedicated for animal studies. So I think these pretty accurate measurements because they're all validated in animal studies. Yeah.
And I've just got one more question.
Sure.
You obviously, and this is probably a little bit mean because this kind of spans both of your presentations, but you've obviously done a lot of work with the EF1 measurement.
Yeah.
Do you think that that is going to replace the normal EF measurement in the future, or are we a long way off from that?
I don't think it's going to replace ejection fraction, but just another measure probably could for people to look at when you evaluate a patient. So obviously, we have been using ejection fraction for the many years, and it's always been the gold standard measure. Although we have a strain being introduced again for the past many years as a kind of fairly new measure and supposed to be more sensitive measure in measuring heart function, but it's not being well adapted in non-cardiac field. So if we want to introduce something to non-cardiac specialists, we want to have a nice and simple concept. For example, EF1 is just a different type of ejection fraction. Maybe easier for like GPs or non-cardiac specialists to understand the concept rather than to tell them what a strain is. So maybe I'm hoping that EF1, if we could do more studies to prove the clinical utility of that measure, it can be widely used. And because such a simple measure can be measured from any standard clinical echoes.
That's great. Thank you very much.
Thank you.
So that brings our speakers to a close, and we'll deliberate and decide who we think will be the Investigator of the Year, which will be presented just after the debate by Dr. Delgado. So really hope to see you all there. Thank you so much for a good session.